Good afternoon, everyone. We're going to wait just one more minute as folks are joining our behavioral health community of practice. So if you'll just hang in there for just 1 minute and then we'll get started. Okay, it looks like everyone is in. Welcome, everyone. We have a packed agenda for today. I want to thank everyone for being on today for UK Healthcare's Behavioral Health Community of Practice. Today's session is going to focus on mental health screening tools. So our first community of practice session last month was focused on tools for training your team to respond to the behavioral health needs of your patients. And this month, we're going to focus on screening and how to do those tools. Overall, the purpose of our behavioral health community of practice, we can go to the next slide, thank you, Mindy, is to share best practices and disseminate evidence-based guidelines, also to connect all of us to community resources, as well as to one another across the behavioral health continuum of care to help us ensure that we have the very best atmosphere for dealing with the current very large increase in the number of behavioral health needs that we have here in Kentucky. Today we have joining us, if we'll go to the next slide, a variety of folks. So we're working with a variety, if we could go back to the green screen, Mindy, sorry, one back. We have a number of folks from community mental health centers, primary care providers, certainly the UK Healthcare a team of specialists and providers who are going to talk about our experiences, but we also really want to hear from you. And we also have a number of community-based organizations and state-level organizations as well. So thank you all for being here today and giving us the gift of your time. We're going to start off with our first presenter, who is Julie Goski from our partner New Vista. We're so delighted to have her with us. Julie is Regional Director of UKHC Health Initiatives. She's a licensed professional clinical counselor, and she has been with New Vista for a little bit over a decade and has a wealth of experience to share with our teams. She's going to be talking about a number of behavioral health screening options that primary care providers can use. So Julie, go ahead and take it away from here. Thank you for being with us.
Great, it's great to be here. I'm sure most of the people on here don't know what a CCBHC is, so I'll just quickly say that that is a certified community behavioral health clinic. It's a state project with SAMHSA that is allowing us to integrate primary care into our community mental health services in a nutshell. So I'm happy to be here. You can go ahead to the next slide. In terms of mental health screenings in primary care, and you can move ahead. There are a lot of questions about why this is important. And really, we're looking at the prevalence, the severity, and the effects of mental disorders and the impact that they have on our clients and patients. And particularly post-COVID, we know that we have a lot of people coming in the door with problems that have maybe not been addressed over the past 2 years or so. So the severity and the effects are perhaps worse than they might have been just a few years ago. Next slide. Mental health disorders can impact someone's employment, both in terms of them being underemployed, losing jobs, making poor decisions at their jobs. It can lead to victimization and other types of trauma. Untreated mental health disorders can lead to suicide attempts, and it impacts someone's financial stability as well, either through that employment or underemployment, the cost of getting care and the time off that might be needed to get care, things like this. When we take all of those things together, it suggests that there's a significant need to screen for mental health disorders in primary care practices. For many of our clients or patients, primary care is not only often the first access point, but sometimes in some communities, it is the only access point for them to get into care. So next slide. So within the primary care world, what are symptoms that might be seen? What might someone come in with that you would notice? Talking about feeling sad or feeling down, but also being confused, having some difficulties with concentration, excessive fears or worries, those extreme feelings of guilt or anxiety, extreme mood changes they might report, highs and lows, things like that. They may come in and talk about not wanting to do things that they've previously done, not be involved with friends or activities, not getting along with family that they've previously done things with or been very active within their families. Significant feelings of being tired, not having energy for things, trouble with sleep, inability to cope with their daily problems or daily life stresses, where someone's feeling really challenged by just getting through the day. Having difficulty understanding situations or people, as well as major changes in eating habits. The one thing that I want to caution everybody about as I talk about these symptoms, right, are that all of these symptoms can overlap with multiple disorders. Physical health problems as well can result in some of these things. So it might be kind of confusing to see this and try to figure out what that patient is really bringing in the door. So next slide. Or not. I can wing it if the slide's not moving. All right. So the other thing that we're seeing a lot of, I'm sure everybody's read the statistics about overdose deaths in Kentucky. And so there are other signs of alcohol or drug abuse that you might be seeing in a client. Someone might come in and talk about DUIs. They might have a blood alcohol content over 150 and the patient's walking around and talking and doesn't seem like they're impaired or seems minimally impaired by a blood alcohol that high. Another key is a history of 2 or more non-sports related traumas, broken bones, head injuries, fights, things like that. When you see something like that, a good idea is to start looking at whether or not we should screen for drug or alcohol use. Injuries while intoxicated, and then use of multiple pharmacies and multiple lost prescriptions. At New Vista, we do run a residential treatment center as well as a methadone and Suboxone treatment center. And I can tell you from my experience with this part of our organization, typically clients come in there with, they definitely are reporting, a broken leg that was never healed. Oh, I got that jumping over the wall that one time or whatever. Things like that. People that have deferred that kind of healthcare, they didn't get that injury addressed at the time that it occurred. Maybe they've had multiple car accidents, things like that. So that is where we start asking questions and start trying to determine what's going on with a client. All right, next slide. So the most common screening tools, and I'm sure a lot of you have heard of these, but the most common screening tools that we talk about are the PHQ-9, which screens for depression, the GAD-7, which is screening for anxiety. At New Vista, we use something called the CAGE-AID, which screens for alcohol and drug abuse. And then the audit is a 10-question screener that looks at alcohol use, and the DAST is a 10 or 20, depending on which version you choose, that screens for drug use. These are quick. These can be the patient can administer them themselves. If you are super lucky and you have a patient portal that can accommodate that, a lot of these can go through your patient portal as well, so that they can be completed prior to a visit. All kinds of fun, quick, and easy ways to start a conversation with a client. All right, next slide. So I want to talk a little bit about the PHQ-9. Basically, it's a depression screen. It's for ages 12 and up, and 9 questions. Like I said, you can self-administer that. You can have someone complete it through the portal. All kinds of ways that you can work that into your screening. I've had occasions where they ask it at the front desk as a patient is checking in. They're asking these questions. So when a patient scores over 10, that is generally an indicator that they are experiencing some moderate depression. And then once the higher that score goes, the more severe the depression is that they're likely experiencing. So of course, like anything else, we would want to make sure to rule out any kind of medical causes of depression, want to make sure that the person maybe isn't just going through a bereavement process, and then also checking with them about a history of mania or hypomania, just to be sure that this isn't bipolar disorder, as kind of some fast things to rule in and rule out. There are also a number of different PHQs. There's a longer one that's 15 questions. There's a shorter one that's 2 questions. Overall, they're really good at indicating whether or not someone has depression. Obviously, the PHQ-9 is the most commonly used, but you could look into any of the others if you felt it was more appropriate for your own practice. The PHQ screeners are free, which is always helpful, particularly for those of us in the nonprofit world. So you can find them at phqscreeners.com, or really you can put it into Google and find it anywhere if you want. But this one is a fast way to look at depression. All right, next slide. So the GAD-7 is very similar to the PHQ-9. It can be administered the same way. It's 7 questions, and it's really going to look at any scores over 10 are going to indicate a probable anxiety disorder. Definitely will need further evaluation to make sure of what exactly is going on with that particular patient. But again, 7 questions can be administered a bunch of different ways, and someone can answer quickly and easily, and you can look and see whether or not you have to have a further conversation about what's going on with that person. So, all right, the next slide. So the Cage Aid is one of my it's one of my favorite screeners. We use it all the time at New Vista simply because it's 4 questions. It looks at both drug and alcohol use, and basically just asks if they felt like they needed to cut down, if they've been annoyed by people who criticize them about drinking or drug use, feeling guilty, and then needing to use drugs or alcohol to like steady their nerves or get rid of a hangover. This one, again, like this isn't diagnosing, right? This isn't telling you that the person definitely has a drug or alcohol problem, but it is allowing you to know whether or not you need to take that conversation further. And it's correlated really highly with the diagnosis. When these things are present, we're looking to talk to the person a little bit more about what they're using and the frequency of use. So, all right, the next slide. So the other alcohol and drug screening tools, like I mentioned before, the audit and the DAST are both separate, one for alcohol, one for drug use. Also, there's something called a single alcohol screening question, which is part of the HEDIS measure for alcohol use. That is a 1 question asking you about your use. And I will admit that I was at first a little skeptical of whether or not 1 question was an adequate question to really get at whether or not someone needed further assessment for their drug and alcohol use. But the research shows that it is highly effective, and it does correlate pretty closely. I believe the rate is like an 84% sensitivity rate for that single question. So it is another tool that you can use, again, very quickly and know whether or not to begin that conversation. The CRAFT is for adolescents, and we use that at New Vista as well. It's very similar to the CAGE, but it is tailored to adolescents and some of the other situations that adolescents might find themselves in, like behaving recklessly or in dangerous or high-risk situations. So it's looking at those as well. And all of these can kind of be found and their descriptions are at that Health and Human Services website. Next slide. So when you get this screening tool and someone's answered 9 questions or 7 questions, and it looks like indeed they might have a mental health problem that is coming up for them. How to respond to that positive screening. And the first thing that we always like to caution everyone, including our therapists at New Vista, is that a positive screening indicates a need for further assessment. It is not an immediate diagnosis. And that screening, the screening should be it should be part of a conversation. It shouldn't be the end of the conversation. You might be able to then help that patient in accessing community resources, making sure that they can find where in their community someone might be able to help them. We work closely with a lot of primary care providers in our outlying counties, and we want to be sure that a primary care doctor can refer that patient right over to us and get in and have them be seen and talk to somebody further if that diagnosis is indicated or the person seems like they're in a lot of distress from their symptoms. Also, really important to encourage that patient to talk to their family, include family or some kind of social support in their care. We find a lot of times people feel very alone when they have mental health disorders, feel like maybe they don't want to talk about it. So being able to talk to a family member, a friend, or have some other kind of support to get them into care is an important thing, particularly like young people, but really it's everyone. It's always helpful to have someone else who can help them access the care that they need. 988 is our new suicide prevention hotline. It works a lot like 911 in that if you call 988, they will do a suicide and risk assessment and make sure that you are safe and get you help if you are not safe. So that is an easy phone call and it's easy to remember, particularly again, if you are involving that family member and letting someone know, like if their thoughts get worse, if their feelings get worse, if they feel like they might be suicidal, that they have options. The text option of 741-741 is another option. We find a lot of our clients prefer to text and are willing to say a whole bunch of things over text that maybe they wouldn't say on the phone. So there is that option for people. And it is really important that they know that they can go ahead and use that. And then lastly, I of course put on here our New Vista helpline. We are staffed 24/7. We always have someone available to get appointments set. And also that same number will reach our crisis line. And actually 988 will eventually reach our crisis line as well because we operate 988 in this area. So we've expanded our crisis services a great deal to make sure that we've always got something available, that we're always available to help when needed. So that is it from me.
Julie, thank you so much. That was such a great overview of the various types of screening tools that could be of use to primary care practices. I really love the fact that you emphasize the 988 number because I know you all are the kind of local resource for helping with that. I think it's so important for folks to know that that's not just a kind of a national hotline out there, but that it connects to local resources. And if you're in a different part of the state than the Bluegrass region, that 988 number will connect you to the local community-based mental health service provider in your region as well. So folks really are connected to local resources. I think that's great. Thanks for emphasizing that. Also too, you may, as a listener, have questions of Julie. So we're going to move on in just a second to our next round of presenters. But I want to make sure to emphasize that if you do have questions, as our presenters are going through, please feel free to put those into the chat at the bottom of your screen, or maybe at the top, depending upon how your computer is set up. The Zoom tools have this chat feature, and please feel free to enter your questions into that feature as well. And also, as we're going through, you might be wanting to jot down some notes about our presenters, some things that you might like to see or hear. We'll have a survey at the end of the time where we would love to get your feedback on today's session, anything we could do to help you more, and then also any additional feedback or questions that you have that we could then answer during our upcoming behavioral health community of practice sessions. So again, thank you, Julie, for that. Next up, we have Lindsay Jasinski and Mark Woods here from UK Healthcare and Eastern State Hospital. So Lindsay is our Chief Administrative Officer of Eastern State Hospital. She's also a licensed clinical psychologist here at UK Healthcare. She's been here since 2010. Dr. Lindsay Jasinski and Dr. Mark Woods. Dr. Mark Woods is our Chief Nursing Officer of Behavioral Health at UK Healthcare and also at Eastern State Hospital as well. And Mark was responsible for a couple of folks who were responsible for helping to roll out our suicide screening and depression screening program here at UK Healthcare. They're going to be focusing on suicide screening and tools, and specifically how to leverage your EHR in the inpatient setting. So kind of taking what Julie had talked about, this broad availability of tools out there, and they're going to talk specifically about how they in the inpatient setting use tools, and hopefully that will be helpful to you all. So Lindsay and Mark, thank you so much for sharing your expertise. We really appreciate it.
Yeah, thank you.
Yeah, thanks, Trudy. Well, I'm going to, much of our work every day, I'm going to hand some things off to Mark. He's going to hand some things off to me. So we're going to share the load here. Like Trudy said, we're going to focus on suicide screening a little bit more in depth and the importance of that, as well as some examples from UK about how we've been able to use our EHR to improve our efficiency here. So on the next slide, you'll see some data specific to Kentucky. This is from the American Foundation for Suicide Prevention. This is readily available data and looks at Kentucky compared to nationally how we're doing. Won't say a lot about this other than to say that we have some opportunities here. I want to point out the statistic in the top right box there that 75.11% of communities as of 2021 said they did not have enough mental health providers to serve their residents. That's really important because what that means is that the need for screening in all healthcare settings is significant across our state. We also know that there are significant deaths, mortality, and morbidity as a result of suicide attempts. So screening is a significant way that we can help impact these numbers. On the next slide, I love the graphic because it shows, pre-1995, there have been a ton of work that's gone into reducing the impact of health conditions such as AIDS, heart disease, and cancer. But if you look at the trajectory, suicide deaths have actually increased since that time. And a lot of the work that went into, addressing heart disease and cancer is based heavily on screening. And so I think that's the work that we need to apply to suicide as well. And then on the next slide, we show a study. This many of you may be familiar with. This is a kind of a seminal study back from 2002 that really is a driver for suicide prevention screening that has happened throughout healthcare facilities. If you look at the statistics at the top, of those who died by suicide, 77% of them saw a primary care provider in the year prior to their death, almost half of them in the month prior to their death. And that's our opportunity. That's our window where we can say, we can make an impact by doing the screening and asking these questions. And you can compare that to how many saw a mental health provider, and many, many more are seeing a primary care provider for other reasons than are seeing their mental health provider. So that study really kind of is a landmark in some of the things that have happened since then. I'm going to turn it over to Dr. Woods to talk about some of those kind of regulatory pieces and then how UK has implemented a process around this.
Thanks, Lindsay. So on the next slide, we will, let's see, one more. We will take a look at, so for many of you, this is the sort of Joint Commission sent event alert 56. That was, for many of us, that is seared into our brains. And that's where they essentially called out for all hospitals that really this was an important endeavor, and it gave us a lot of our initial sort of guidance on what we should be doing to prevent suicide and care for those that come into our hospitals that are suicidal. And so in 2019, though, the National Patient Safety Goal 15.01.01 was replaced that, and there was a lot of things that they learned. And so one of the things that they had learned is that the inpatient estimated the annual inpatient suicide rate of 3.2 per 100,000 psychiatric admissions, but 0.03 per 100,000 non-psychiatric admissions. And that's important because in the very beginning with Sentinel Event Alert number 56, they were requiring that we, or suggesting that we actually screen everyone coming into all of our hospitals at any point for suicide. And that sort of, after they did that study, it certainly allowed them to make the change that universal screening is really not necessarily required per this new National Patient Safety Goal. It's only if that person comes in the hospital with that complaint or with a behavioral health sort of history, or that's their main sort of reason for being there. All right. The next slide. So we'll talk a little bit about best practices. And so we've got a lot of things that we're going to be talking about in the upcoming slides, and a lot of things that we'll show you. And just like Trudy said earlier, these slides will be made available to you. So if we skip over something that was sort of you felt like you wanted to be able to go back and look at, I think you'll have that opportunity to do so. But this slide, we wanted to sort of capture what are some of the best practices around suicide. And for many of us that have been in the behavioral health world for a long time, some of these things on the left-hand side, things we no longer do or no longer think are best practices, we'll be very familiar with them. So things like contracting for safety. Many of us can remember back in the day when that's what we did with patients that were suicidal. We essentially said, you're not going to hurt yourself. And if you don't hurt yourself, and we need you to sign off on this contract and make that sort of declaration to us. And we know now that that's not effective, and it's not evidence-based. And now individualized safety planning is really more of the best practice for that. And again, that's Joint Commission sort of gave us that direction to do just that. Screening only, we used to just screen people with a really sort of made up screen or something that we sort of cobbled together. We felt like these are the questions that we should be asking to sort of, verify someone's suicidality. And now we know that we have to have valid tools. And we also have to have follow-up assessments in addition to interventions. We also used to send all patients with risk to the ED for inpatient evaluation. And we now know that really it's sort of a tiered approach now. Now we know there's various levels of risk, and that sometimes that risk can be managed outside of the hospital with follow-up appointments or with engagement with a community mental health center or a therapist. And then we also know that constant observations for any risk for suicide. There was a day and time when if a patient was in your care or came into your hospitals and they were there for suicidality, we would just put them on a close or a sitter or whatnot. We now know that constant observation or sitters really should be identified just for those that we say are high risk for suicide and not necessarily low or moderate risk. All right. So the next slide will sort of illustrate, again, another piece that Joint Commission says that we have to make part of all of our processes on inpatient settings. We have to sort of stratify the risk or have levels of risk for patients that come into your hospital with the complaint of being suicidal. And so the one that we use at UK Healthcare is one that's very similar to this: low, moderate, and high. And at your high risk, they also say that you should with each one of these levels that you have to have an appropriate level of triage. And for those that are high risk for suicide, it's very highly likely that those persons are going to be admitted. Those that are low risk or moderate, they a lot of times an outpatient referral may be the most appropriate intervention, or some other supplementary sort of supports, if you will, but definitely some safety planning. All right, next slide. So as we go through and we talk about these tools, I think an important statement for us to make is that these tools do not replace your clinical judgment, because many times these tools have been used very almost robotic-like, right? In a robotic-like manner. And, we're asking the question and we're filling them in. And what we know sometimes is that the patient isn't always forthcoming. And they're not always, and so sometimes we have to gather other information from family members or loved ones and peers or people that were with them prior to this hospitalization. And so we really emphasize this part to our clinicians as well. And what that means is sometimes it may mean that the tool told us that they're low risk or they're moderate risk. But when we collect all of the information from family members and whatnot, we may say, actually, we feel like the risk is much higher. We feel like maybe the patient isn't being as forthcoming with us as they could be, and the risk should be higher. And we do just that. So we encourage that with our clinicians here at UK Healthcare. The next slide should be a few tools as we talk about suicide tools. Before we show you what we use at UK Healthcare, we wanted to just introduce to you that there are other tools that other organizations may use, and you really just have to find the one that fits your practice. And we've listed 3 here. The last one is the Columbia Suicide Severity Rating Scale. That is what we use at UK Healthcare. We'll talk in the inpatient setting, and so we'll talk a little bit more about that. But the PHQ-9 is also something that sometimes facilities or clinics might use. It is it really kind of rates more passive suicidal ideation. And so if they do screen positive for this passive sort of suicidal ideation, you'll have to do a more intense risk assessment for sure. And really the PHQ-9 is more of a depression sort of screen. The 9th question does address sort of suicidality, but for inpatient hospitalizations, Joint Commission really pushes against using the PHQ-9 alone for the suicide process. The ASQ, the ASQ is, the NIMH is something that is created by them. It's very short, takes about 20 seconds to administer, and it's 4 yes/no screening questions. And oftentimes you'll see this in clinics, outpatient clinics, or just sort of like private sort of offices or whatnot. And again, that's another option. But here at UK Healthcare, we use the Columbia Suicide Severity Rating Scale for our EDs and for our inpatient units. It is validated for children, adolescents, and adults. It has ratings for passive and active methods for suicide or thoughts of suicide, the plan, intent, and suicidal behavior. And we do use the levels of risk that the Columbia Suicide Severity Rating Scale suggests as well. And training is free of charge to use this. All right. So UK Healthcare, again, for the ED and our inpatient units, we do this. We actually choose, even though Joint Commission says you don't necessarily have to do this sort of universal screen, at UK Healthcare, we actually do that. We universally screen in the ED and on our inpatient units for anyone that's 12 years of age or older. For those that are 11 years of age or younger, they're only screened if they present with a behavioral health concern, sort of what Joint Commission says, right? If the patient's screened low, moderate, or high, we do a further assessment. We'll show you what that looks like and talk about that. We have a team, psychiatric intake team, and they're the ones that do our lifetime assessment. So people oftentimes conflate a screen, which is what we do for all of our patients 12 years of age or older, and then they often conflate it with the actual lifetime assessment. A screen and assessment, very different. And so if you screen high enough or positive, we then come in and do a more robust lifetime assessment that is also the Columbia, the CSSRS. And this is done, and so if that patient is admitted to the unit, then we actually do a reassessment every 12 hours until we have a negative screen. All right. And so this is, you're gonna, the next couple of screens, and this is where we'll sort of go maybe a little faster. You'll get to see sort of what the actual screen looks like sort of in our computers. I'll point out a few things on each of them. But to the left of the screen, you'll see the actual Columbia Suicide Severity Rating Scale, and it is a screen. So it's, it's a total of 6 questions potentially. And that's what that looks like. You can actually go and get that on the website. It's called the Lighthouse Project website, and all of their stuff is free. But on the right, you can see how we've integrated that into our electronic medical record. We use Epic. And so you see those questions, and there's drop boxes. So if there's a positive response or whatnot, it'll drop down another, maybe another box for them. And below, at the very bottom, you'll see how we had to create an algorithm so that it actually determines the risk for us as we answer the questions. And so that's something we sort of had to work with our Epic team to create, but that took a lot of the guesswork out of the screenings for us. All right. And this is an example, this will kind of zip through this a little bit. This is an example of the lifetime assessment. It is the Columbia Lifetime Assessment. I do want to point out again that what you just saw was the screen, just so that you don't conflate it. And then this would be the assessment, the corresponding assessment for someone that had a positive screen. Okay, the next slide. And this is what that lifetime assessment looks like in our Epic electronic medical record. The icon at the very top is how our psych intake team is notified if there's a positive screen. And so the physician goes in, clicks the order, hits accept, and that notifies the psych intake team to come see this patient, the room that they're in, and perform this much more robust lifetime assessment. Okay. And then this is just a reassessment. So if that person were to be admitted to our units, this is just a couple of notes for how we at UK Healthcare manage the reassessment. So the nurse will do the reassessment using the CSSRS since last contact form. They've got all these forms that are free for you. And they do this every 12 hours for anybody that's found to be high, moderate, or low risk. We do this on the behavioral health unit for every patient, regardless of their risk. So every 12 hours, we're doing this reassessment. If the patient no longer scores at risk for suicide, that's when we contact the physician and we work with them to take the patient off observation and reduce sort of that intensive observation, if you will. All right, next slide. All right, and this is the screen that I was just telling you about. This is what the nurses will fill out, and you can see to the right of that column how they've filled out those questions. And on the behavioral health unit, again, they'll do this for every patient, a reassessment every 12 hours. And if that person were admitted to, say, a medical unit and they were high risk, this would happen only for that person on that medical unit. Okay. And so we wanted to show you a little bit about how we use the electronic medical record to improve patient outcomes. And so this is a part of our suicide sort of program, suicide prevention program at UK Healthcare, and it involves patient safety planning. And I know our friend Julie Goski is certainly familiar with how we do this and why we do this. But this is based off the Stanley Brown safety planning sort of model. And you can see there are 6 very distinct areas for us to fill out or to work with the patient. And it's important to know that any patient that comes into our facility with a complaint of suicide, whether it's low, monitor high, we're going to start this patient safety plan for them, and they will get this and receive it when they leave the hospital. And it's a way for us to work with them on identifying warning signs, identifying coping strategies, and then also identifying people in social settings that actually help them, right? Along with their phone numbers. And then we also give them on step 5, you can see there to the right, professionals or agencies that I can contact during a crisis. And so they have numbers of these individuals. And so our psych intake team works with them to create this personalized patient safety plan. Okay. And I think I covered all of that in just telling you about it. The one part I would note is at the bottom of this slide, it's really important for us, is that we do partner with our friends at New Vista with our suicide program at UK Healthcare. So in our ED, if someone shows up that's low risk and they're not going to be admitted to the unit, what we do is we utilize that 24-hour help hotline, I think that Julie showed you a little bit earlier, and we get connected with New Vista to sort of set that individual up with an urgent appointment within 24 to 48 hours of their discharge. That is, of course, if that patient's willing to engage in that process with us. And so that's just a really important piece that I wanted to point out for our patient safety planning process. Next slide. And Lindsay.
So in the interest of time, I'm not going to go over this in depth, but we wanted to provide a couple of tools and resources. So the Rural Health Information Hub is actually a great resource. They have a suicide toolkit that includes all of these questionnaires, as well as toolkits on how to implement these, how to use an EHR, how to train staff, all of those kind of things. And then a similar toolkit on the next slide is available as well. This one is specific to primary care practices, which I think is really great, from the Suicide Prevention Resource Center. So those tools are excellent resources. They're comprehensive. They have workflows. They have implementation checklists. They have everything really that you would need to make sure that you are implementing a comprehensive suicide screening and assessment practice. I think, Trudy, that's it for us.
Thank you all. That was so helpful. I know that our suicide screening was an enterprise level initiative that happened before COVID, and we were so glad that we did that work and had that available, just because of the huge increase in the need of patients. And so obviously we have a number of folks who have both kind of like primary care roles, health system administrator and leader roles, and others. So we want to just provide you the whole gambit. So the next speaker who's going to talk is Patty Hughes, Dr. Patty Hughes. He was Chief Nursing Officer in Ambulatory, and she and Mark were really our two kind of lead people. Obviously, it took a huge team to pull this off, but they were our lead folks who helped to implement our screening processes for suicidality across the organization. And Patty's going to talk about what we do in our ambulatory clinics and how depression screening, that PHQ 2 and 9, play such an important role in identifying those behavioral health needs. Patty?
Thank you, Trudy. Appreciate it. Next slide, please. So Trudy's correct in that depression screening and suicide was a relatively new work for many of us in ambulatory. Our primary care clinics do the best job and did the best job when we first started some standardization. So I just want to go through a couple of slides and just talk about the quality metrics and kind of repeat what Mark said about Joint Commission, then tell you what the process is. Next slide. Next slide, please. Well, while we're getting that next slide, I'll go ahead and talk. So depression screening is a quality measure that both CMS and and Medicaid directed payments hold healthcare systems accountable for. And when you look at the quality measures that that we're held accountable for, it really is about quality, and it's about safety of our patients. Now, certainly there are dollars attached to some of these things, and that's important, but it drives what we hope it does is it drives the practice of our clinical teams to ensure that we're providing the very best care for our patients. So on the slides that I think they're getting ready to bring back up, I've just got the definition of the quality measure, and it very specifically talks about who we monitor and who is excluded, and you can read that for yourself. And then we look at suicide screening, and as Mark already mentioned, it's a national patient safety goal. And so, when you just take out all of the really difficult language, if you can go on, Kelly, to the suicide, the national patient safety goal, it's a lot of words when you look at the Joint Commission manual, but what it boils down to, it's our responsibility as a healthcare system to reduce the risk of suicide. And then the next slide I put on there is that really this is just the right thing to do for our patients. I mean, that's why we should do it. Certainly, we like to have these national organizations guide our practice and help us standardize the care we provide across the country. But given the complexity of daily life, work life, certainly what we've been through the last couple of years, it's the right thing to do for our patients. And so at UK Healthcare, in our ambulatory clinics, we started this journey. I was looking back at some of the dates around depression screening in about 2017, and we piloted paper questionnaires in some of our primary care clinics. And so certainly we've gotten more sophisticated than that now, and we've developed a protocol. And the protocol is a rooming protocol. If you can go to the monitoring slide, that says as our MAs, our RNs, our LPNs are rooming our patients, part of the work we expect you to do is to ask those questions around depression. And we want to screen our patients, and the expectation is that we do it annually, but the practice is the MAs do it with every patient, because we want to make sure that specifically when a patient shows up in one of our specialty clinics, that we're capturing those patients as well as capturing them in the primary care clinics, because again, the primary care clinics are very good about annual screenings. So as part of our rooming protocol, we've done lots of education around depression screening and what you should be asking and how you should be asking those questions. It's uncomfortable for some individuals to have that conversation. Next slide, please. And so what we want to make sure that these individuals know, it's just really very important how you ask the question. You need to be sensitive, compassionate. You don't know what's going on with every single patient, so we want that across the board. And then ensuring that there is that you kind of check the tone of your voice, that you're very encouraging, and that you watch your nonverbal behaviors. We recently, next slide please, shared with our staff during what we call our fall blast, some scripting techniques. And so again, because we know that this at times is uncomfortable for folks to ask these questions, we gave them some examples of how to have this question with an individual who maybe is not in a primary care clinic, but they're in a clinic for a totally different reason. And we just want them to feel comfortable saying, in order to provide the best care for you, we screen every patient for depression at every visit. And then you ask permission to ask those questions. So we just launched this probably a couple months ago. We've given them scripting techniques before, but this is so important that we remind them of this almost annually. Next slide. So as Mark said, ensuring that we document is important, but in the ambulatory care environment, when we ask those questions, it's better for us to have a cascaded process of asking questions. So we initially ask the PHQ-2, we ask a couple of questions, and then we ask the ninth question. So we kind of modify that a bit. In our adolescent patient population, we ask the PHQ-A, which is slightly different in that there's some more specific questions about suicide and attempts. But we initially ask the PHQ-2, and then if there's a positive response to that, we ask the entire PHQ-9. Then if there's a score that's greater than 3, or there's an affirmative answer to that last question, we then ask the CSSR. We go, so we cascade from a few questions that can be asked of every patient, and then digging into what's going on with this particular patient, so that we can ensure that those individuals that need our assistance get that help that they need. Next slide. So as I said, we go into the short version of CSSR. We document those. Obviously, we document this, and if the patient, we deem that the patient is high risk, we then have a suicide protocol. And it was interesting when I was looking back over the suicide protocol. We developed this suicide protocol in 2016. So this was a long time before we did this work around, depression screening and suicide screening. And it was a direct result of an incident we had in a clinic where we did a swarm. And for those of you that don't know what a swarm is, that's our QI process where we really dig into an issue to see if there's some failures in the system. And so we developed our protocols back in 2016 so that we could guide our clinicians, our staff in our ambulatory clinics to ensure that the patients got what they need, because we in ambulatory don't have access to social workers, psychiatric mental health specialists, at the numbers that our inpatient side does. We certainly don't have enough there either, but we really don't have them in ambulatory. But we wanted to ensure that our patients got what they needed. So next slide just shows you, so we wrote a policy, and boy, Mark and I worked on this forever, and we thought it was such a good policy, and it was an enterprise policy. And when Joint Commission came this last time, I guess we were told we really weren't doing that great of a job with our policy. And the recommendation was that because there is such different practices on the inpatient side and the ambulatory side, that we needed to split those policies out, which we have done, and have updated them based on Joint Commission feedback. So this is current, and it basically goes over everything that I just went over. Next slide. And then here are 2 protocols that we have. And as I said, we've had those in place since 2016, because we know that patients, they may indicate that they are suicidal, not just in the physician's office, but they may call and have those same conversations with our patient access team or one of our staff members on the phone. So we wanted to make sure that we had step-by-step what an individual should do to ensure the safety of our patients. So we've got both of these protocols in place that we've educated widely on. And I know that I need to make one update. And again, it was based on something that Julie said, so I appreciate that. And so we'll make that update after this meeting. One thing I did want to point out on the next slide is, we talked about, this being, a CMS and a Medicaid directed payment, a quality metric. And we look at this all the time. I look at my friend Trudy Matthews, and she knows this like the back of her hand. But we look at this information more than one time a month. We probably look at it every week because we want to make sure that if our clinical staff are not able to ensure that we're screening and following up appropriately, that we provide for them the resources that they need. So again, that we can keep our patients safe. And that's really all I have for the ambulatory piece. I think we do a good job at this. We certainly look at this all the time and make tweaks in our policies and our protocols based on situations and based on different regulations. But that's all the information that I have for you. So thank you very much.
Thank you so much. We're going to skip over our kind of follow-up question in the interest of time and get to our panel. But Patty, you did a great job. And, obviously a lot of work from a lot of folks have went into this comprehensive approach, and took a number of years. And we do analyze those quality metrics to make sure we're, capturing as much as we can all of our patients who are in need, have any kind of behavioral health needs. So I want to introduce really quickly our panelists. We've got Maureen Dennis, who's a director of psychological testing at UK Healthcare, Dr. Jenny Gottschalk, who is our acting chair of Family and Community Medicine, and then of course Patty, who just spoke, to talk about just really quickly a few questions that we know come up a lot with folks who are looking at implementing some kind of screening. So first of all, one of the things that comes up is like, hey, you're gonna have patients that come into your office for a sprained ankle or an ear infection, and and they're going to be puzzled. Why are you asking me about my mood in that visit? And so can you talk about how you deliver depression screening in a way that makes sense to those folks who are coming for some other kind of visit? And we can have, either Patty or Jenny, either one, talk about that question.
Sure, I can jump in. So I think that for some patients, this is unusual if they're not used to going to a primary care provider on a regular basis. I think for our patients who come pretty regularly to family medicine, they know we're always asking about all kinds of questions that may seem unrelated to why you're there. But I think a lot of that has to do with just talking with your rooming staff. So the nursing who are having that first contact with the patient is just letting them know, like, hey, this is just making sure we're getting a good picture of your overall health. We're going to ask a bunch of questions today. We do the depression and the suicide screen, but we also ask about falls and, all kinds of other things that might seem unrelated to what they're doing at the time. So I think if that's part of the normal process of the nursing staff kind of giving that kind of preamble, then the more they come, the more they get used to that.
Patty, anything else you want to add to that?
No, I couldn't have said that better myself. I think it's training and scripting.
Yeah, and really that care for the whole person, regardless of the reason for their visit. The next one we want to talk about is a question that we have is really related to how you respond to someone who is suicidal, but is maybe refusing help or any kind of follow-up care. Maureen or Patty, do you want to talk about how you would suggest that folks deal with that in their practice?
Sure, I can jump in on that. I would refer back to, I know Mark in his talk, gave the examples of different things for following up when people are acknowledging suicidal, either thoughts or intentions. And so I think some of it is just taking the time to stop and to talk to the individual to find out, what is going on that they are not interested in accessing any help and trying to really listen to their perspective on things. There's a lot of evidence to show that actually the more that the clinician and the patient feel like they're collaborating with each other, that actually that helps the patient kind of divulge a little bit more of what's going on with them. And if the provider is comfortable talking about suicide, that actually opening up that conversation can be really helpful to the patient right there in that moment. So that can be really a successful intervention. Also, it helps the patient feel heard so that then you can respond by, perhaps listening, hearing what they're saying, and then maybe trying to infuse in some suggestions of ways that different types of interventions could be helpful, or connecting with someone, finding a supportive person. I think people have given a lot of different options of different kinds of safety plans that could be put in to action. So I think a lot of it is just taking the time to stop, listen to the individual, and then try to respond starting with where they are.
Great, thank you, Maureen. Also too, kind of last question, because I know we're running out of time here, is, there are always those concerns among providers, like we have such a limited amount of time with our patients. How do you, for Jenny and Patty, with both specialists and primary care providers, how do you encourage that understanding of whole person care for providers that have only that 10, to 15 minutes or even less with to spend with the patient? What do you say to that concern?
I think that is always hard because in an ambulatory setting, you just always feel the rush of the clock because there's 3 more patients outside the door waiting for you. But I think one thing is just thinking about that whole person care doesn't necessarily mean every visit we address every part of that person, but it's continually assessing the whole person and recognizing we have to prioritize. And even though maybe they came in because of the sprained ankle, you can address that pretty quickly. But if you pick up on this, which is a very serious issue, we have to take the time, extra couple minutes to address that as well. And, maybe I had on my agenda, I also wanted to talk about some other things, but I have to just prioritize that based on, the information that I've gotten from my nursing staff and then my initial assessment when I get in the room.
And the only other thing that I would add is, I think it's, part of my role is to ensure that our nursing staff are as efficient as they possibly can be, and that they understand the why behind some of the questions that we ask, so that we can maximize the time that our providers have in the rooms with our patients.
Couldn't have said it better. So thank you guys. Well, and we're going to wrap up today. Thank you all for your time, the gift of your time. Just really quickly want to make sure that folks who are interested in having their staff participate in mental health first aid training, obviously there's a QR code on the screen, and that's also available through our website for the Behavioral Health Community of Practice. Those are going to be offered for free to you all between January and April. So there are a variety of times. It's just a really great way to introduce this type of training for dealing with mental health or substance use disorders. Also, we're going to ask, if we could go to the next slide, we're also going to ask you to fill out a survey. If there were particular things that you thought were really helpful today that you want us to amplify, or if there are other questions that you have, please let us know through that survey. We want to make sure that every community of practice meeting is as effective as it possibly can in delivering to you just the right amount of information in the time available. And we really always use that for continuously improving our work. And then I want to say thank you to all of our presenters and staff who helped put together today's Behavioral Health Community of Practice. We really have a wonderful team with lots of different gifts and expertise to bring to bear. And we look forward to hearing from you. Our next Behavioral Health Community of Practice will be December 1st, 2022 at noon. That one will be on using use of alternative visit types and talking about telehealth and other types of models to expand access to behavioral health care. Thank you all again for being with us today. Hope you have a lovely day and get a chance to enjoy this beautiful fall weather we've been having. Thank you again. Bye, y'all.